Hi, Dr. Centeno. Thanks for joining me this morning. And got a good topic, I think. It occurred to me the other day that while it's very evident to me which nerves are in places where they can get irritated, that isolating each of the nerves, the deep cervical nerves that get irritated, and then spending some time trying to dissect each one, talk about what each one can do, would be worth doing for the CCI community, because we often hear about these nerves, vagus nerve, hypoglossal nerve, cranial nerve 10, cranial nerve 9, various spinal nerves, and others. But, there isn't much discussion, I think, of where they're probably getting irritated, why they're probably getting irritated, and how all of this works. So I wanted to spend some time this morning going through all of that, and then obviously open it up to questions. Now, I've been bouncing around on the best time to hold a Facebook Live. Right now, we're going to go back to Sundays, see how that works. I've done these in the middle of the week, so I'm going to spend some time doing that as well. But we'll see how things go. So again, today we're going to be talking about 7 deep cervical nerves that make CCI patients miserable, and then sort of going through each of these nerves, going through what each one does, what kind of symptoms they cause, and specifically where they're getting irritated. And then go to the same Q&A format that I have had. So now that I'm back in town for the summer, I'll be back doing these probably on the weekends, but you guys let me know whether the weekend is better or whether it's better to have them sort of during the week, later in the evening. I'm open to either one. So let's get into the topic today, and then we'll go into Q&A as well. So again, 7 deep cervical nerves that make CCI patients miserable. So the nerves we're going to be talking about today are those that are around the C1 and C2 transverse processes. Now, there are other nerves as well that are in front of and in back of C1, C2, but we're really going to focus on those nerves that are right around these transverse processes. Now, the transverse processes, if I'm a vertebra, the transverse processes are like my arms. They come out on the side of the C1 and C2 vertebra, and you can see those here. So this is a transverse. Process here of C1. This is the transverse process of C2. Now, C1, C2 is big in rotation. 50% of all your neck rotation happens at C1, C2. So you might imagine that these nerves aren't getting irritated every time someone turns their head, so that they have evolved in such a way as to be able to stretch and to be able to be covered by certain types of fascia that allows C1 and C2 to rotate. So the problem isn't so much that C1 and C2 is rotating, because half of your neck rotation comes from C1, C2. The problem comes in when we start to get these abnormal motions that we see in instability. And that in C1, C2 very commonly could be a side-to-side motion. And that doesn't usually happen, right? So if we look at a DMX and we try to look at one of the things we see on DMX that's commonly associated with craniocervical instability, that would be this side-to-side motion, or C1, C2 overhang. So this isn't something that these nerves have evolved to be able to take. So when we get C1, C2 instability like this, these nerves start getting pissed off. And each one of these nerves traces back to symptoms. Now, we can look at this side-to-side, left-to-right instability, but there will also be some instability of C1 forward, C2 forward. For example, so C1 can go forward if we've got a transverse ligament laxity. And again, that's going to bring that transverse process of C1 forward or backward, forwards, backwards, again, another motion that these nerves really aren't able to tolerate. So just in conclusion, any nerves that are in close relationship to C1 and C2 transverse processes can get irritated by instability at C1 and C2. How do you fix this? Usually you just reduce the instability, and that then lets the nerve calm down. Now, if that doesn't work, you can also precisely treat the nerves with hydrodissection. Obviously, the first one's a very elegant solution. The second one is just adding another tool in the toolbox. So let's start with cranial nerve 10, vagus, because I think vagus is the one we hear about most often. And vagus is involved in so much stuff, it's almost scary. It's involved in swallowing. It's involved in speech. It goes into your GI tract. So if it's irritated, you can see gastroparesis, problems with digestion, disruption of the gut-brain axis. If it's irritated, since it's the brakes on the heart, you can see tachycardia. Problems with blood pressure, problems with inflammation, because it actually jacks into the spleen and has to do with the release of certain white blood cells. You get Chiari area pain in the posterior dura and cranial fossa. You get ear canal pain. So vagus by itself is jacked into so many different things. So it would be interesting to see, and there's a little video here, where that vagus lives, right? So we can see it here. It lives right in front of that C1 transverse process and right in front of the C2 transverse process. So both of those areas are spots where it can get irritated. It could even get irritated right in front of C3 here. So as you can see, but mostly at this C1, C2 area, and especially at C1, we can see there that the area where it's most likely to get pissed off based on its distance is going to be right in front of that C1. So if C1 is moving around too much, that vagus can get irritated. Now, not in everyone who has C1 and C2 instability, because it all depends on what their anatomy starts with, how that nerve is able to handle some extra force. Specifically, what extra forces in that person's instability are irritating that nerve. So now let's go to C2 dorsal ganglion. This would be headaches in the back of the head. And this becomes the greater occipital nerve and gives rise to some of the parts of the lesser occipital nerve. Now, realize when we hear about greater occipital nerve, we're really thinking about that greater occipital nerve as it's superficial back here. So if you get a greater occipital nerve block, they're not blocking this area that we're talking about right now. This area is much deeper. So just realize that even though it makes up part of the greater occipital nerve, if C2 is getting irritated at the back of the C1, C2 facet joint, as I'll show you, doing all the blocks out here all day long and twice on Sunday, the kind you would get in the average doctor's office visit or when you go see your neurologist, isn't going to make a darn bit of difference because you're not injecting the right spot. So let's look at this one here. So what's really interesting is that this is the C1, C2 facet joint. So this is C1, this is C2, that's that C1, C2 facet joint. And notice that the C2 dorsal ganglion, which is this thicker part, runs right behind that facet joint. So again, if you're getting abnormal motion of that facet joint because you've got C1, C2 instability, then that's potentially pissing off that C2 dorsal ganglion and giving you a big old headache in the back of your head. Again, it's the greater occipital nerve way the heck up here. So if I'm going to block it up here, but it's really getting pissed off over here, this is not going to do anything. So now the good news is if you do a C1, C2 intra-articular facet injection, i.e. a real one, not a fake one, meaning it's under X-ray guidance with contrast confirmation, digital subtraction angiography, then by default, you're treating that C2 dorsal ganglion. But the percentage of patients that are getting treated in CCI who are getting that area treated is slim and none, and Slim's on vacation in Texas simply because most clinics don't have the ability to do that deep C1-2 injection, whereas for us, it's common. We do it all day, every day. Oh, wait a second here. What happened? Not sure why that ended there. Oh, did this not update? Sorry, guys, this was completed, but well, guys, I apologize here. I ended up completing this up in the mountains, and for some reason it did not update here. Don't know why that is. Let me try one more thing here. I'm going to stop sharing for a second while I try to figure this out. Well, guys, I apologize. For the rest of the nerves, I had finished those up at our place in the mountains. And for some reason, it doesn't look like it updated to my OneDrive. So I will have to complete this. I'll just put out a separate video on the rest of these nerves. There's 5 more that I did. And I also have almost complete all the YouTube shorts on each one of these. But I'll put out that video separately once. I'm not quite sure. It may not be till next weekend when we head back up there again. For some reason, it was saving locally up there and not to the cloud. So apologize, but let me just go to questions here because we've got a lot of questions coming in. But I will get that out to you. So I apologize on that. Again, I finished it up at our mountain place and did the other 5 nerves, and then it doesn't look like it updated to the cloud. So, okay, let's start taking some questions. Maisie, I'm not quite sure how to pronounce that. Which nerve compression instability creates the most fatigue? Well, fatigue is an interesting concept, right? Fatigue could be created by anything that causes lack of sleep. So if you're having difficulty getting restful sleep due to any neck condition, including this one, then you're going to have substantial fatigue. Now, this one could cause some very specific types of fatigue because if you get vagus nerve irritation, you can get in constant fight or flight. So if you're in that constant fight or flight mode, then you're really going to have a hard time entering restful sleep. So those would be the 2 mechanisms, but I would say cranial nerve 10 would be the one most reliably causing problems like that. Got that one already. How do you know the difference between a contracted muscle or if a nerve has become stuck and tight? Example, nerves that run through the levator and trapezius. Yeah, I think what you're asking is how do you know the difference between a muscle that's maybe reacting to biomechanical forces Like, my head's always shifted this way. Therefore, one of my upper traps is going to be very tight versus a pissed off nerve that's making the muscle tight. And the answer to that is if there are biomechanical forces that explain the muscle tightness, could be instability as well, then that's usually what's causing it. If treatment for that doesn't help, then you can always treat the nerve that goes to the muscle. Now, if you're in a situation where there really isn't much rhyme or reason why that muscle is tight, then you start thinking about the nerve that goes to the muscle. So a great one would be the upper trap and accessory nerve. If your head is shifted over or you've got scoliosis, you've got a reason for one upper trap to be tighter than the other. Having said that, do we see cases where the accessory nerve is pissed off and therefore the upper trap is tight? We do. The accessory nerve is very easy to hydrodissect and treat. So in those cases, you would want to treat the nerve, not necessarily the underlying biomechanics. So hopefully that answers that question. Amen. If I have AI because of EDS, would fusion be good for my case? Fusion is always the court of last resort, right? It's a non-elegant solution. So for example, usually C1, C2 would get fused. Well, 50% of your normal neck rotation on a day-to-day basis comes from C1, C2. So if we fuse C1, C2, i.e. we make it not move at all, then you're going to lose 50% of your neck rotation. Having said that, you need to rotate your neck to live. So let's just take driving a car, right? If you're going to be driving a car, you're constantly going to need to be looking to the right and left. You're going to need to look behind you to back up. Certainly, you're going to need to check your rear quarter on that side, your rear quarter on the other side. So every time you do that, if C1, C2 is fused, 0-1 is getting beat up, or what's called adjacent segment disease, as is 2-3. So there is no elegant solution with fusion. Now, there are patients that need it, and if you need it, you need it, and you have to go with an inelegant solution that's probably going to cause another problem down the road, i.e. adjacent segment disease. But you wouldn't start there because that would be the court of last resort. Julie, if PICL can affect the AO vectors, when would you expect this to happen post-PICL? Immediately after some time? Usually it's after some time, Julie, in my experience. So usually what happens is a patient has been getting adjusted. They're doing well with those adjustments. Then we do PICL, and then usually around month 2 or 3, the chiropractor is coming back and saying, I think your vectors have changed. So kind of in that time frame. Carol, submitted advanced by Sherry Scott. Are issues with these nerves something that your neurologist can diagnose? Not usually, no. The average neurologist isn't going to know much about what's going on with these nerves, regrettably. The biggest problem there is the average neurologist is not trained in biomechanics of the spine. Now, there are some that are out there. For instance, James Gaddis was one of our fellows. He's a neurologist. He went through interventional pain fellowship. Then he did our fellowship. He's the 1 in 200 or 300 neurologists that understands the biomechanics of the spine. But that's very rare for neurology. Remember, neurology is an offshoot of internal medicine. So internal medicine docs don't know much about biomechanics. It's not what they're taught. They're taught medications, they're taught systemic physiology, but they're not taught biomechanics. So I think any of this, in discussing this with the average neurologist, is going to go way, way over their head because they're just not educated from scratch in the biomechanics of the body or the biomechanics of the spine. Julie, how soon after PICL do you recommend beginning the laser exercises, resume spine and low-level exercises? Tabal has taught me. I don't want to disturb the stem cells at work, but motivated. Julie, the answer to that question is in the rehab videos I put together. So let me direct you back there. Let's go to the share here. Hold on a quick second. So if you go to my channel here, and you just go to videos and scroll on down, you're going to find the rehab videos. So the first rehab, these are all the rehab videos here. So the first rehab video is going to be way down here. How to rehab from CCI part 1, this one. And then it goes into the part 2 videos and then into the part 3 videos. These are designed to kind of focus in on your functional level and then focus in on various parts and pieces. But what this would describe to you is that your job in recovery is to thread the needle. So what I mean by threading the needle here is very simple. And that's starting with this one here. Threading the needle would mean that you could start as soon as things calm down from your procedure. So let's say you're flared up for 2 weeks. At the end of that 2 weeks, you've got to thread the needle between starting to gain some strength, but not aggravating things so much that you put yourself into a big flare up. So at the end of the day, watching those videos will really give you a lot of information about how to proceed. Elving, could some form of CCI cause red hot ears? I can take it when I lean. I can get it when I lean my head back on a cushion on the couch. Yeah, Elving, that could be irritation of the greater auricular nerve at C1, C2 there. That could be irritation of other nerves as well. Parts of the vagus nerve, parts of the hypoglossal nerve innervate different parts and pieces of the ear. So that can be CCI related based on those nerves. It's been advanced by Harry Winston. If you have neck instability, should we be wearing a neck collar or would that make the neck weaker? Yeah, I think the question here is an important one, and that is when it comes to wearing neck collars, that's another thread the needle concept, right? So much of rehab in this area of the upper neck is thread the needle. So here you're threading the needle between if you wear a cervical collar and that can dramatically control or reduce your symptoms, then you'd want to wear a cervical collar in situations where you know you're going to get very aggravated. So for example, let's say you have to fly in a plane or go in a car. You're only spending maybe just a handful of hours each week doing those things. So wearing a cervical collar just for those is probably not going to create a lot of weakness. Having said, then you'd want to get out of the cervical collar because if you're in the cervical collar too much, it's going to cause weakness. So that's a good example of threading the needle. I'm in the cervical collar only as much as I absolutely need to be, so I'm not getting dependent on it and causing my muscles to get weaker. So realize that a cervical collar, any use, will cause weakness in the muscles. So you would want to dramatically limit that use to only situations where if you don't use it, you're going to develop issues. Again, it's been advanced by Harry Winston. What type of physician and what type of imaging is needed to determine if these issues are what's causing the problem? Yeah, so I think the answer to that question is, let's go through that real quick. I mean, the problem we have still is we don't have many true experts in craniocervical instability out there. And so they are very, very, very few and far between. For example, we've got about 5 surgeons that do about 80% of the elective surgery worldwide. And there's probably just a handful of doctors who do any type of, with any frequency, upper cervical interventions. And then you get into those doctors can be graded from only understand how to do very simple injections to maybe do a little bit more complex, but they're probably pushing the limit a little bit, i.e. they're not using the proper tools. Let's say they're trying to use ultrasound to inject the upper neck. Bad idea. To the doctors who are even fewer and far between who understand how to do advanced fluoro-guided, contrast-confirmed digital subtraction angiography, etc. Then we get into doctors who are doing PICL. There's a real ePICL as we perform it, and then a bunch of fake PICLs that are out there where the docs are just faking and baking the PICLs. So it's a very difficult area to understand, which is why I do these videos, which is why I have the Reddit page. So let's go there. So if you're not on the Reddit page, you probably should get on this. We're up to about 450 members now. I answer these questions, as people know, 7 days a week. Just trying to make sure we've got good information going out there for the CCI community, because as I look at these social media channels, they're a mess. Sometimes you get good information, sometimes you're getting awful information. And for example, because 3 people who were allowed, X didn't work for, but X worked for 20 people who are quiet. All of a sudden, we shouldn't do X, i.e. on social media. So be extremely careful on social media. And it's one of the reasons why I'm so active on social media. I'm so active doing these Facebook Lives. I'm so active answering patient emails, etc. Joanne, if someone gets re-injured, i.e. I would assume maybe another car crash or something, a couple of months after a PICL, would they need to get an ASAP for another treatment, or the previous stem cells still work out the new injury? Previous stem cells at that juncture are probably not going to work to help the new injury, but what we have seen is that there's been some subsequent healing, and the patient rebounds much more quickly than would be expected. Joanne, when would the new become stronger after a PICL? I think maybe new tissue there. So again, it's important to understand those phases of healing, right? We start out with acute inflammation. Acute inflammation is going to last anywhere from a couple of days in really young people to maybe a couple of weeks in older people. And that's when you get swelling in the area, you bring new cells in to start that healing process. Then you start to lay down new tissue after that's completed, and that's generally happening from, let's say, the first week to maybe the second or third week, all the way out to about 2 months, where new tissue is getting laid down. And then we get into the third part of healing, which would be remodeling, where the body is fine-tuning that new tissue, trying to make sure that it's appropriately organized in order to take the loads and demands that are required on that tissue. And then that's going to happen from, let's say, that 2-month mark out. For younger people, it maxes out at 3 or 4 months. For older people, it might be 6 or 9 months before that maxes out. Elving, do you know if there is an upright MRI and DMX in the same city in the USA with good resolution? I don't live in the USA. Sure, I think there's lots of cities, Elving, that probably fit that bill. Denver is one of them, for example. We've got lots of DMXs and an upright MRI. Parts of Florida would fit that bill. California is probably underrepresented in that list. Parts of New York might, but again, a little underrepresented in that list. And then I'm sure there's other cities I'm not mentioning that have upright MRIs and DMXs, but that's just kind of off the top of my head. Hey man, I took a Viagra pill out of curiosity and it made my head pressure way worse. I felt my head and face throbbing. It gave me some headache. It doesn't confirm IgB compression of blood isn't draining. I don't know the impact of Viagra on intracranial hypertension or decreased IJV outflow. There probably is one. Meaning that Viagra works by reducing the venous outflow from the penis. Now, how much that extends into the peripheral system, I don't know. It's probably not all that well studied, I would imagine. But it's certainly possible that could have decreased venous outflow from the head and the neck. But I would be surprised if we knew a lot about that one. Joanne, when would the areas injected with PICL become stronger after the procedure? Yeah, I think I just answered that one, Joanne. So for most people, it's going to be in that couple of month time frame. Joanne, does the C2-3 facet joint cause dizziness, doctor, or more instability from the ligaments? C2-3 facet joint is a big one for causing dizziness and changes in position sense or proprioception, and is a big driver of dizziness in a lot of patients. Other drivers of dizziness can be the higher up neck joints, usually 1-2 more than 0-1, as well as the small muscles, suboccipital muscles, can also do that. Papaya. Would those C1, C2 nerves affect any sensations into the heart? Is there an artery in that area? It might send a pain to the heart. Really, that's going to be more vagus nerve, papaya. So vagus nerve is the one that has the biggest impact on heart. Cranial nerve 9 can have an impact on blood pressure, but really the vagus nerve is probably going to be the big driver there. And it's not going to be so much a pain in the heart, which obviously you need to get investigated because lots of other things can cause pain in this area. But assuming all of those things are ruled out, I would say the vagus nerve, and we think it's from craniocervical instability, the vagus nerve would probably be the biggest one to look at. Julie, Dr. C, will hydrodissection of bilateral occipital nerves help with other affected nerves, glossopharyngeal, accessory, etc.? No, hydrodissection of the occipital nerves will help with other things like the C1 innervation of the suboccipital muscles, including that rectus capitis posterior minor. And that's if you're doing a rectus capitis major plane hydrodissection. But it won't help with issues with glossopharyngeal and accessory. If there's a thought of glossopharyngeal involvement, then the best thing to do is to treat the instability through a PICL procedure. And for accessory, same thing. Now, those can also be hydrodissected separately if needed, but usually glossopharyngeal doesn't need to be. Accessory usually doesn't need to be, but sometimes might need to be. Submit advanced by Sherry Scott. My neck is made worse by laying down. So I literally sleep in a chair with pillows on both sides of my neck to keep it in place. Is that going to be made worse? Or is that going to make it worse in the long run? Yeah, Sherry, well, I think there's probably a certain value to the little bit of stimulation for the muscles that your neck would get while you're sleeping. Probably not that much, right? If you're in deep REM sleep, your muscles aren't doing much to protect your neck. But we're only in deep REM sleep maybe half the time when we're laying down to sleep. The other half the time we're not. So half of that time, your muscles are going to be active. So if you're creating a situation where your muscles are completely inactive at night, it's probably not going to have a huge impact, but it will have some impact on those muscles, meaning making them weaker, but not nearly as much, for example, as if you're wearing a cervical collar during the day. Courtney, for someone who is dizzy, off balance, what spot in the neck is responsible for that? It's an upper cervical spine thing. The most common level would be C2-3. Or next from that would be C1-2. But it's a classic upper cervical spine symptom. It's one of the ways that we know that the upper cervical spine is probably involved, meaning that we can stimulate just the neck without stimulating the inner ear, and the dizziness comes on. And that's an upper cervical spine thing. Caleb, Schultz told me I'm hypermobile now. Let me go to this next one, sorry. Schultz told me I'm hypermobile. How effective is the PICL on people with EDS? Actually, I never knew I was hypermobile because I've never been very flexible, but now I know I can bend my thumb to my forearm. Yeah, Caleb, so we looked at this not too long ago. There's some old videos on it where we didn't see a huge difference between EDS, the outcomes of EDS patients and normal ligament patients with a PICL, other than we believe that it takes more procedures in hypermobile patients versus non. Courtney, is there any PT that could be done prior to PICL? What is the best resource to figure out if you have EDS hypermobile? Yeah, the PT or the prehab that's done prior to PICL. We normally recommend Todd Ball and his program. He's got a prehab program before PICL. That's online. And then what's the best resource to figure out if you have EDS hypermobility? The best resource there, or the simplest one, is just going online and looking for a Beighton test or a Beighton score and going in and taking that simple online test. That's a easy thing to do. There's lots and lots of Beighton score tests out there. I think the Zebra Society has a really good one online. You can score it yourself and get some information as to whether or not you look hypermobile. Now realize that there's also patients that aren't generally hypermobile but have spinal hypermobility. So regrettably, it's not going to be able to detect that. But you can usually detect those patients because those are people who can bring their head back to their upper back, for example, meaning the back of their head literally can touch their upper back. So if you're looking at doing flexion extension upright MRI or flexion extension x-rays, and you can bring your head all the way back to your upper back, but you can't do the splits, you maybe have spinal hypermobility without generalized hypermobility. Macy, or Maxi, I'm not sure how to pronounce that, I apologize. Can CCI symptoms work like this? Feeling tired in the shoulders and neck, 2 hours later the headache comes, and the neck pain comes. They can, but realize that craniocervical instability specifically means that you're unstable in the upper neck. That could be craniocervical syndrome, where the upper neck is causing symptoms, and that would be the headache component of that, or maybe something else entirely. So none of those symptoms, as they're described, would jump out as craniocervical instability, but they might be due to craniocervical instability. So let's just explore that for a second, right? What would jump out as craniocervical instability? I got into a car crash. Ever since the car crash, I've been dizzy and I get headaches, and any movement of my neck will make all of that worse, including that messes with my vision. Or if I turn my head down and to the left, every single time I do that, I get problems with my vision and dizziness. And when I put on a cervical collar, it all goes away. If I see an upper cervical chiropractor, it all goes away, but it doesn't last. I've got to go back in there once a week. And so now we're building a fact pattern that starts to look a lot like craniocervical instability. Papaya, 3 months post-PICL, I had a car accident and everything held. I was so happy not to have headwear or hardware in my neck. Yeah, great to hear, Papaya. I think that goes with what I talked about before, right? I was discussing that concept that we've had people who've gotten in other car crashes and then noticed that they're either recovered more quickly than they expected or didn't really take the same hit that they had previously because things were stronger. Heidi, do you recommend prolozone therapy versus a steroid shot? Well, let's dissect that. Steroid shots anywhere in your body are bad for you. So there's no doubt about that now. We have lots and lots of research on this, really going back to the 1950s. And more recently, we've got a slew of randomized controlled trials that a corticosteroid injection in any joint in your body is going to harm that joint and harm that patient. Now, why are those still done? Because they're still covered by insurance, but frankly, they shouldn't be, or at least they should only be in rare circumstances and with expanded informed consent, i.e. the patient signs a piece of paper that says, you're going to inject this stuff into my knee, and I fully realize that you're going to destroy some of my cartilage by doing that. That's not what happens. As far as prolotherapy goes, prolotherapy can be very helpful in tightening ligaments. When it comes to CCI, it can be helpful in certain kinds of CCI, but not in the internal type of CCI at C1, C2 that we're describing here, or at least not usually. Then we get into prolozone therapy. Prolozone therapy is just a type of prolotherapy. And prolozone therapy, we're not sure if it adds anything over regular prolotherapy. And it's not even really all that kosher here in the United States because we don't have any ozone, medical ozone machines we can use that are approved here in the United States. So prolotherapy, prolozone, kind of the same thing. Those are in general going to be better than a steroid shot. Neither one of those is going to solve internal craniocervical instability like a type 2B all that well. So hopefully that context makes sense. Joanne, what would cause pain behind the eyes with CCI? Could this be nerve-related problem? Yeah, so pain behind the eyes can be caused by lots of different things. Sometimes it can be related to the occipital nerves being irritated back here, because sometimes there's this pain that patients get that goes from here to this behind the eye sort of headache. Sometimes it can be related to irritation of the superior cervical sympathetic ganglion. Sometimes it can be related to other issues having to do with neither one of those. But if it's CCI related, those would be the two. Heidi, Tallahassee, Florida has a stand-up MRI. Gotcha. Moon Gnome. What about lack of proprioception in the arms and the neck? Is that possible? Yeah. So any kind of craniocervical instability or craniocervical syndrome is going to create lack of position sense, which is proprioception, in the neck and head. And then that could also affect position sense in the arms. Now, position sense in the arms or lack of position sense in the arms can be other things as well. Things like a central cord syndrome or syrinx. Things like problems with the nerves in the upper arm. So peripheral neuropathy, for example, can cause poor position sense in the arms, or a pinched spinal cord in the lower neck can cause lack of position sense in the arms. So while upper neck issues can cause that, we'd probably also look for other things that might be able to cause that as well. Joanne, can stem cells help hypertrophy ligaments? Yeah, we don't want to hypertrophy ligaments. Generally, hypertrophy of a ligament or tendon means that it's big and not strong. We want small and strong. So the goal of a stem cell procedure would be ligaments that are small and strong, not big and weak. So hypertrophy is big and weak. Which CCI type is most common in occipital neuralgia? Yeah, pretty much all CCI types can contribute to occipital neuralgia. So I don't know that that's a good way to try to focus that down on a specific type. The best way to get typed is to do the testing. So that's digital motion X-ray, upright MRI with flexion extension, those sorts of things can help with typing. But occipital neuralgia is going to be common in most CCI types. So it's not going to be a way for us to focus in on one type over the other. Jayesh, it's definitely nerve irritation causing plethora of issues. Can you check Dr. Hauser research as well on YouTube? Yeah, I don't need to check Dr. Hauser research for sure. So I'm not quite sure the point you're trying to make here, Jayesh. Listen, I think Dr. Hauser does some great, very simple prolotherapy in the neck. And that can be very helpful in certain types of craniocervical instability like type 3A. It's not going to be helpful in the other types of cervical instability. In fact, a large portion of the patients I see on a day-to-day basis have failed that type of simple prolotherapy, many of those coming from Hauser's clinic or elsewhere, because it's not dealing with the internal ligament issues. And then as far as the testing they do there, I'm not in agreement with. I've got a bunch of videos on that showing that the type of testing that's done there, in my personal opinion, is not helpful in trying to diagnose and treat craniocervical instability. But I'm not quite sure what the question is there for me. Heidi, husband has degenerative disc disease in the lower neck, but has major pain at the base of the skull. Nothing shows that MRI, CT scans. If all blood work comes back normal, has side headaches and back of head pain. Well, blood work wouldn't be expected to tell us much about why he has head pain, nor would an MRI or CT scan usually tell us much. Now, it's possible that because of weakness lower down, there's some overload of the upper neck. So that can cause headaches. It's also possible that there's a separate issue in the upper neck that's not going to be found on an MRI. You've got to do a good old-fashioned hands-on exam and spend time with the patient. So regrettably, blood work is going to be pretty useless in trying to figure out why someone has a headache due to degenerative disc disease at 5, 6, 7, or anywhere coming from their neck. An MRI or CT scan is also, in general, how it's used on a day-to-day basis, not going to be that helpful. Now, for example, on the MRI, if you had someone that knew how to look for upper neck atrophy, but that's not going to be looked for at the neurology office, that's not going to be looked for at the family doctor's office, that's not going to be looked for at the orthopedic surgeon's office, that's not going to be looked for by the reading radiologist. But if someone looks at that, that might be helpful. But if that's there or not, you're probably not going to know. Cynthia, my daughter has been supine for a few months due to her instability. It's led, I think, to oxygen saturation problems. What can we do to help her, given her CCI symptoms when she's upright? Yeah, Cynthia, that's a question that would require much, much more in-depth analysis. That's something like a telemedicine where we have you fill out a dozen pages of a questionnaire. We review all your history. We review all of the imaging, including movement-based imaging, to see if there's craniocervical instability. And then we actually do an interview with the patient, and then all of that is put together into recommendations. But as far as social media diagnosis, that's not the purpose of this type of format here. Julie, is there a correlation between damage to facet joints and ligaments that occurs if a patient delays their care, gets a PICL later, or does this affect recovery chances? Yeah, Julie, one of the things that we see is if we get someone, for instance, within the first year of a traumatic injury, and we treat that person with a PICL, then more likely than not, that's a single treatment. But if that person waits another year and we're 2 years out, then more likely than not, that's 2 to 4 treatments. So that can make a big difference. We also see a lot of times that patients sort of put this off. And the biggest problem with time here is instability plus time equals damage. So, if you have to put it off for a month or 2, it's probably not going to make a big difference in the scheme of things. But if you put it off for a year or 2, that could make a huge difference in what is getting damaged due to the instability and how hard it is overall to treat. Caleb, sure. Julie, and can this be seen during PSAL? Sorry, hit send too soon. I think you're asking about facet joint damage. The answer is you can see facet joint arthritis and damage as a big picture, not really granular, but as a big picture on an MRI. So for example, it's not uncommon for us to see an MRI from time 0 and then see it 2 years later and notice that certain facet joints have more arthritis. So you can make those determinations in general on MRI. Jayesh, will IJV compression go away after fusion? Well, there isn't a problem with IJV compression, Jayesh, so we got to be careful here. This is something that patients misunderstand, and frankly, a lot of doctors misunderstand. And that is that lots of people are walking around with IJV compression and have no symptoms. What's probably causing the symptoms of the IJV compression is intermittent extra compression. So assuming a fusion gets rid of that intermittent compression, the answer is yes. But remember, a fusion is a court of last resort treatment, meaning it's not an elegant solution for CCI. So we only do fusions in patients where there's no other way to help them. It's not a first line, second line, or even third line treatment for CCI. It's the court of last resort because it can create as many problems as it solves. Having said that, there are times that you need to do a fusion, and there's just no other way to skin that cat. Ferdy, can you rule out or confirm CCI when the only thing you have is an upright MRI? You can, and I've got a bunch of videos on that topic. The issue there is an upright MRI would with flexion and extension. So an upright MRI without flexion and extension is pretty useless in determining if someone has craniocervical instability. If it has flexion and extension views, then it would be good at maybe detecting about half of the kinds of cervical instability, but it will be not helpful for determining if someone has the other kinds of craniocervical instability. If we had to lay a bet on, let's say, an upright MRI with flexion and extension and a digital motion X-ray, and we had to bet which of the two, if we could only pick one, was more likely to find craniocervical instability if it were present of all types, it would be the DMX, would be more likely than the upright MRI with flexion and extension. And then that being different from an upright MRI without flexion and extension, which is pretty useless, not 100%, because there's still some kinds that you can find on there, but for the most part, very unlikely to find craniocervical instability when it's present. Realize again, craniocervical instability is a movement-based problem, hence you need movement-based imaging to find it. If you don't have movement-based imaging, the likelihood of finding it goes way, way, way down. Courtney, can you please name the guy you mentioned again for prior PT to PICL? Yeah, that's Todd Ball, Todd and then B-A-L-L. If you just look up Todd Ball physical therapy, he should come up. I developed anhedonia from lack of blood flow to brain and vagus nerve dysfunction. Certainly vagus nerve dysfunction can cause that type of issue. Gotcha. Is lack of pain very unusual for CCI or possible? It is, but it makes the confidence that we're dealing with CCI less. So for example, we rely on certain things to try to have a good understanding that CCI is causing symptoms. So those would be common symptoms, would be one of those, right? Headaches, dizziness, imbalance, upper neck pain. And then another set of things would be what makes it better, what makes it worse. Moving my head around makes my symptoms worse. Putting a cervical collar on makes my symptoms better. Upper cervical chiropractic makes my symptoms better. The more of those things we have in line, then we do imaging. And the more of those things we have, check, 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 the more likely it is we're dealing with symptomatic craniocervical instability. When we're missing certain parts and pieces, like there is no headache, there is no neck pain, it still may be CCI causing the symptoms, but our ability to say that with high confidence goes down. Now we might have moderate confidence and realize that the lower the confidence level that we have that upper cervical instability is causing your symptoms, the more likely it is that we might help your upper neck stability, but not change your symptoms. So just realize there that that's what happens. Rachel, same here. Collars reduce my symptoms significantly. Jayesh, will all nerve issues go away after treatment? Well, that really depends on the amount of nerve damage, right, Jayesh? That's why if you get someone within the first year before that nerve damage has set in, then that's usually a very easy patient to treat. But the more nerve damage you have for longer periods of time, the harder it gets to make everything to go away. Having said that, even in those patients, we're still running about a 7 in 10 success rate and helping enough so the patient doesn't go on to a fusion. So that's pretty good, but that still leaves 3 in 10 patients of those more chronic people where the damage is just too much. Oli, can cervical instability cause excess hunger and abdominal cramping? Not excess hunger, abdominal cramping unlikely. So again, lots of things can cause excess hunger, metabolic syndrome, blood sugar instability, et cetera, et cetera. Lots of things can cause abdominal cramping. So you would want to get the workup there to make sure that none of those things are causing issues. And then we can entertain the concept of whether or not craniocervical instability might be causing those problems. Kate, arm. My C1, C2 are being crushed front and back, causing severe stenosis. Is there anything I can do for it besides bolting my neck to my head? Kate, I don't know what you're talking about in terms of severe stenosis or 1-2 being crushed, meaning that those aren't medical descriptions, so I don't know what that means. So I would need to look at your imaging and try to get a better sense of what it is we're discussing here, because stenosis or severe stenosis in the 1-2 area happens, but is pretty rare, even in craniocervical instability patients. So, but I need to know more about what we're talking about here. Does that mean you've got severe C1, C2 osteoarthritis with big osteophytes? How are those osteophytes affecting central canal diameter? Lots of parts and pieces would need to be known to get a sense of what's happening there. Lisa asking for my brother. He wants to know what is the approximate volume of fluid is taken during the stem cell blood draw before it's processed, and approximately what is the amount that is re-injected back in the body. So if we're looking at bone marrow aspirate, the average bone marrow aspirate draw could be anywhere from 60 mLs to a high of about 180 mLs. And the amount that's re-injected for bone marrow concentrate, i.e. a same-day stem cell procedure, might only be 3 to 4 mLs. And for things like PRP, might be 3 or 4 additional mLs, et cetera. So much depends on what products are being used, but on the draw side, anywhere from 60 to 180 would be common. And the smaller the person, the less we can take. So if you're very small, we might have to adjust those numbers. That's then looked at in combination with how much gas is in the tank, so to speak, what your hematocrit is. Kate, the back is being pushed by a thickened ligament. I'm ready to fuse from C3 to T2. So Kate, I need to know what ligament. Maybe you're talking about the ligament flavum being hypertrophied above that. And if you're fused from C3 to T2, then that's a great example of what we talked about before, right? Fusion is not an elegant solution for anything. Fusion is a court of last resort that can cause as many problems as it solves. So it sounds like someone fused you from C3 to T2, leaving only 2, 3, 1, 2, and 0, 1 mobile. And so that means that those segments are going to get adjacent segment disease. And it sounds like you're describing the results of adjacent segment disease, where joints and ligaments start getting hypertrophied because they're getting constantly beat up by the fusion. So that's a great example of what we were talking about before. Oli, how can I fix my neck curve? Do PICL procedures help to fix neck curve? PICL procedures may assist with neck curve, but you're going to have to be doing curve restoration as well to that. And guys, we're coming down to our last 2 minutes here. So just given the 2-minute warning, if you will. Let's see, Dr. Centeno, what causes black spots in vision with CCI? Joanne, there's a number of things in CCI that can cause visual issues. Upper cervical position sense being poor can cause problems with visual coordination. You can get irritation of the superior cervical sympathetic ganglion, which can cause problems with the sympathetic control of the eyes, like pupillary dilation, focus, etc. As far as black spots in vision, that's a less common CCI symptom. So I would look hard for a non-CCI cause there before I pin that one on CCI. Let's see. Roger had 3 PICLs from 2020 to 2021. At DMX4 PICL number 1 and PICL number 2, but not before PICL number 3. So 2 DMXs with PICL 1 and 2. Had another upper cervical MRI, but showed radiolar had regrown. We don't really use upper cervical MRI that way, so that one I'm going to ignore. But my CCI symptoms have come back, chiropractor other than DMX just before, the PICL with more recent MRI. So MRI is not going to be that useful in looking at the status or the structure of your alar ligaments. It sounds like you may need another PICL. And also had a border guard who almost didn't let me in. Patients having any problems. Yeah, we haven't had any problems with patients getting in the country for treatment, but usually that's because they have something that says that they have to come into the country to get treatment. Maybe that wasn't the case there. So it sounds like you might need a fourth PICL, and the most important thing would be a DMX, not another MRI. How common is ME/CFS in combination with CCI? How often does CCI treatment improve ME/CFS? So ME/CFS diagnoses are common in our patient population. Probably 1 in 5 or more of our patients have an ME/CFS diagnosis. And ME/CFS isn't really a thing, so to speak, meaning that in our case, it just means that person has a fatigue component usually. And so fatigue components in our PICL population are common and they usually resolve. So again, realize ME/CFS is a box in which we put people who have chronic fatigue and other painful symptoms. Our goal is to take that box and find out which small portion of that box have those things happening due to craniocervical instability, then to take those people out of that box, further slice and dice that into a specific type of craniocervical instability, and then treat that type of cervical instability. So there's definitely crossover between the two, but there's lots of people in the ME/CFS box that don't have CCI who wouldn't respond to something like this. But for the people that do, they tend to respond very well. Kate, where can I send you my MRI? Yes, you did describe what was happening with my degenerative disc disease. Kate, that would be a telemedicine evaluation. So you would need to go to the Centeno-Schultz website. So if you go to Centeno-Schultz website here, I'm going to keep going until my son arrives. I don't see him yet. So go here to Centeno-Schultz, then go to specialty areas, then go to craniocervical instability, then go to the second one here, craniocervical instability, and a bunch of things are going to come up. You can download, yes, no, whatever. And it talks about the steps in going through a telemedicine. So get us imaging, get typed via telemedicine. So that really you want to get to step 2 here. And obviously it says make an appointment down here. So if you want an appointment for a telemedicine, that would be what you're talking about there. And then Debian, how late is too late to get us for a single PICL procedure cure? Yeah, usually Debian is that 12 to 18 month window. After that, it's going to be more. What is the line, in your opinion, where curve correction is not attainable? I think where curve correction becomes inattainable or much harder to obtain or attain is when we're in a situation where the vertebrae have already started to change shape. So as we get older, if you keep a certain shape of your spine, i.e. lack of curve, your body starts to build bone spurs and to change the shape of the vertebra to accommodate that overall spine shape. And, that's where the ship has sailed, right? We're probably not going to be able to easily change the shape of that spine. Now, that's very different than somebody who maybe only has that changed shape of their spine overall for 2 or 3 years, 4 years maybe. They're a bit younger. Their body hasn't changed the shape of those vertebrae. And those curves are going to be easy to fix. So realize it is possible to get to a place where it gets harder to change the shape of the spine because the change of the or the shape of the individual bones that make up the spine have already changed. So we don't want to get to that point. Okay, guys, I think that's it for questions. I apologize for that, for only a partial lecture today. I'll go through and find that. Might be till Thursday when I get back up to the other site, the work site, and I can go ahead and put out that full video. In addition, all 7 nerves are going to be part of upcoming YouTube shorts. So if you're not on my YouTube channel, I would go and do that now. So if you go to YouTube here and you go to my channel, it's at Centeno Home is my channel. Or if you just type in Chris Centeno on YouTube, it'll probably come up. And go and subscribe there so that you can see the full video when it comes out, as well as the individual 7 different YouTube shorts that'll be coming out that explain the symptoms that go with each nerve and where that nerve is located. So thanks so much for watching. Have a great week. I will be here next weekend. If you're online, either today or on Facebook or on Reddit, then go ahead and let me know. Do you want to see these on the weekends, these Facebook Lives? Do you want to see them during the week, later in the day? Either one is fine with me. Just trying to find a good time that works for everybody. Thanks so much for watching. Have a great day.